Imagine this. You think of a condition as something that mainly affects children, right? Something they might grow out of or, the doctors fix really early on. But what if I told you that over 1.4 million adults in the United States are actually living with congenital heart disease? And for more than 1 in 5 of them, it's a really, really complex form. That statistic, well, it kind of flips our usual assumptions right on their head, doesn't it? It really highlights a critical, rapidly evolving and incredibly nuanced area of medicine.
It absolutely does, yeah. The sheer number of adults living with these conditions is significant, but I think what's even more compelling are the unique medical challenges they present. Like you said, while many got a diagnosis back in childhood, a substantial percentage actually have their condition first picked up when they're adults. So, this isn't just a simple case of a childhood illness that's fixed and then poof, forgotten. It demands continuous, specialized attention throughout a patient's entire life.
That's a really powerful point. Welcome, everyone, to the Deep Dive. This is where we take your sources, articles, research papers, maybe even your own notes, and we pull out the most essential nuggets of knowledge and insight. Think of it as a shortcut to being truly well-informed. We try to find surprising facts and hopefully just enough humor to keep you hooked. Our mission today, our goal, is to really immerse ourselves in 2 critical areas of cardiovascular health. We want to bring you an understanding that's, well, pretty close to what an elite professional in the field would have. We're going to unpack the rapidly evolving world of adult congenital heart disease, or ACHD, and then we'll pivot to demystify pericardial disease.
Yeah, and our goal is for you, the listener, to walk away with a really comprehensive understanding, not just of what these conditions are, but why managing them is so complex and why it takes such specialized expertise. We'll explore everything from the intricate definitions and the frankly astonishing developmental processes of the heart to the specific challenges patients face and the sort of cutting-edge strategies in their care. It's really a journey into the remarkable resilience of the human body and, well, the ongoing innovation in medicine. #I, the evolving landscape of adult congenital heart disease, ACHD.
Okay, so let's unpack this fascinating and, as you mentioned, relatively new area of medicine. First up, defining congenital heart disease in adults. And we just heard that statistic, over 1.4 million adults in the U.S. living with CHD. And for a significant chunk of them, it's complex. That's a huge population needing tailored care.
It truly is. And while, yeah, the majority were diagnosed during childhood, it's crucial to grasp that a substantial percentage, our sources really highlight this, they don't even realize they have a congenital heart defect until they hit adulthood. And that's not necessarily a diagnostic failure, it just underscores the need for a heightened awareness, maybe a higher index of suspicion in general adult medical practice.
So what does that mean then for lifelong follow-up, for something we often link just with childhood, this idea of continuous care, maybe coordinated with or directly provided by ACHD specialists? That feels like a big paradigm shift. Can you help us understand why this continuous surveillance is just so vital?
The profound implication really is this. A heart that started with a congenital defect, even if it was successfully repaired way back when, it's never quite normal. It's kind of like having a house built with a unique architectural design from the start. Even after renovations, it still has its original blueprints, right? The heart and the body keep aging, and those original repairs or just the underlying altered physiology, they can lead to new complications, wear and tear, or subtle changes over time that maybe a general cardiologist might miss. So continuous surveillance is essential to catch these shifts before they become irreversible problems. It allows for proactive, timely intervention. Our deep dive into ACHD today will guide you through this complexity. We'll start by clarifying the specific nomenclature of the terms used. Then we'll delve into the astonishing process of cardiac development, talk about common diagnoses seen in adults, and then explore the nuances of repaired lesions. And throughout, we should keep in mind how vital visual aids are, like figure 269.1 in the source, which illustrates different blood flow patterns. They're really key for grasping the anatomy and physiology. That makes perfect sense. Yeah. This really does sound like a relatively new subspecialty then. Our sources emphasize that the field of ACHD care has kind of blossomed over the past decade. What do you see as the single most revolutionary change that really propelled ACHD into its own dedicated subspecialty?
I think the most revolutionary change is that shift from seeing these conditions as purely pediatric issues to recognizing the unique lifelong needs of adults. This blossoming, as you called it, has been driven by several key nationwide initiatives aimed at standardizing care. Major organizations like the American College of Cardiology and the American Heart Association, they've been pivotal. They first published comprehensive guidelines for adult CHD care back in 2008 and then significantly revised them in 2018. And these guidelines, they emphatically underscore the critical need for really robust collaboration between primary care clinicians and the specialized ACHD teams. That partnership is just vital to ensure seamless and truly comprehensive care across a patient's entire lifetime. Yeah, that collaboration sounds incredibly important for patient outcomes.
Definitely. And beyond just the guidelines, how has the medical community sort of formally recognized and structured this growing expertise?
Right. That's where professional recognition comes in, and it's been a huge development. Landmark, really. In 2015, the American Board of Medical Subspecialties introduced specific ACHD board certification exams. That was a critical step, formally acknowledging the unique body of knowledge and specialized skills required for this field. And in parallel, the Accreditation Council for Graduate Medical Education, the ACGME, established really rigorous requirements for advanced fellowship training in ACHD care. So what that means is that future specialists are undergoing standardized, intensive training, ensuring a consistent and high level of expertise across the country. So it's not just about individual expertise then, but also about the whole infrastructure of care itself. The Adult Congenital Heart Association, ACHA, they developed a process for ACHT care program accreditation. What does that accreditation involve, and why is it so important for patients?
Yeah, the ECHA's accreditation process is really about standardizing the entire ecosystem of care. It focuses on the infrastructural components considered essential for achieving quality outcomes for ACHD patients. So this means rigorously assessing factors like the availability of multidisciplinary teams, surgeons, cardiologists, nurses, social workers, access to advanced specialized imaging, state-of-the-art surgical and interventional capabilities, and robust long-term follow-up protocols. The key insight here, I think, is that this truly shifts the paradigm from relying solely on individual practitioners to developing integrated specialized care systems. It recognizes that quality care for these complex patients requires a unified, high-standard environment, not just brilliant individual doctors working in isolation. This ensures that every accredited program has all the necessary elements in place to provide the highest standard of care, and that demonstrably leads to improved patient outcomes. #Tag 2. Special considerations for the ACHD patient.
Okay, it's crystal clear this is a specialized field. Let's dig deeper now into what makes ACHD patients unique, particularly thinking about subtle changes in their health and the complexities of non-cardiac surgery. Our sources highlight a significant challenge. Adults with CHD might not recognize subtle changes in their exercise capacity. And these seemingly minor shifts are actually associated with worse survival. It's almost insidious, right? Where irreversible physiological changes can happen before symptoms even become noticeable.
That's a crucial point, absolutely. And it's not really about patients ignoring symptoms. It's more that their bodies have a different kind of normal. They've adapted over a lifetime to a unique physiology, and their baseline might just be lower than what's optimal or what they can consciously perceive as a decline. This is precisely why regular proactive evaluations are so strongly advised. These assessments are for surveillance looking for anatomic, hemodynamic, and electrophysiologic sequelae. You can think of it as specialized detective work, really, designed to detect problems before they manifest as severe, undeniable symptoms, allowing for timely, often life-saving intervention.
And that vigilance extends to non-cardiac surgery too, which sounds incredibly complex for these patients. Our sources state that nearly all adults with CHD are classified as stage A, or even greater degrees, of heart failure. That means they harbor risk even if they're not overtly symptomatic. What are the profound implications of this for, say, a routine non-cardiac surgery?
It means they have very limited hemodynamic reserve. Think of their heart like an older car with a smaller engine. It runs fine on flat ground, maybe. But when it hits a steep hill, or in this case, the stress of surgery that alters blood flow and pressure, it struggles to adapt. It simply doesn't have that extra oomph or reserve capacity that a healthier heart would naturally have. Furthermore, they might have what we call subclinical organ dysfunction issues with other organs like kidneys or liver that standard lab tests might not even pick up. And this isn't about blaming general practitioners. It's just about the unique, often hidden challenges these patients present that require specialized foresight.
So the recommendation is quite clear then. A comprehensive multi-specialty assessment and care strategy review before any invasive or operative procedures sounds like a non-negotiable step. And Table 269-1 in our sources, it lays out a whole list of crucial multi-organ considerations during that perioperative period, resuscitation, and recovery. Can you walk us through some of those, maybe emphasizing the overarching challenge?
Absolutely. The key insight here is that for ACHD patients, their heart condition is never just isolated. It impacts practically every system. It turns what might seem like a routine procedure for others into a complex, high-stakes puzzle demanding comprehensive, integrated care. For instance, neurologically, these patients have a higher incidence of occult or hidden strokes, as well as clinically evident ones. They can also experience decreased executive functioning skills, things like planning and organization, and there's a higher prevalence of anxiety, PTSD, depression, and other psychosocial disorders too. These are critical considerations, because they impact not just physical recovery, but also a patient's overall well-being and their ability to engage with their own care.
Wow, okay, so it's not just about the physical recovery from the surgery itself, but their mental and neurological state is a huge factor too. What about other organ systems, like head to toe?
Right. In the lungs, we often see restrictive lung disease and pulmonary vascular disease, which significantly impacts breathing mechanics and gas exchange. Renally, they might have decreased perfusion, potentially leading to chronic kidney issues down the road. Hepatically so, in the liver, fibrosis is a significant concern, especially in certain complex ACHD conditions where blood flow through the liver can be altered long term. Looking at the peripheral vasculature, there's often increased chronic venous insufficiency, meaning their veins struggle to return blood efficiently, which can lead to swelling. The lymphatic system, too, might have impaired reabsorption, further adding to fluid management challenges. Orthopedically, things like scoliosis and kyphosis, curvature of the spine, are common and can affect posture and even respiratory function. And lastly, hematologically, anemia is frequently seen, which directly impacts oxygen delivery to tissues, reducing their capacity for healing and recovery. So, anesthetic management for these patients, it requires a profound and very specific knowledge of their unique anatomy, the physiologic consequences of their underlying defects. Their myocardial and vascular performance, any previous procedures or residual shunts, altered pathways, and critically, the status of all these non-cardiovascular organ systems. It's truly a full-body approach. Every single detail matters.
That's incredibly comprehensive. It really underscores the absolute necessity for that specialized care. Now let's turn to another very specific and delicate consideration: pregnancy in women with CHD. Our sources state that preconception counseling is absolutely crucial regarding both maternal and fetal risks, and that care should ideally happen in institutions experienced in treating CHD during pregnancy.
Indeed. The preconception evaluation includes a detailed medical history, paying particular attention to the woman's functional capacity. That links very closely to both maternal and fetal outcomes. What's fascinating here is how the World Health Organization, the WHO, has classified risk during pregnancy for women with heart disease. You can see this in Table 269-2. There are 5 classifications: WHO I, 2, T, 3, 3, and 4, each with increasing risk of maternal mortality and morbidity. The essence here is that pregnancy dramatically alters the body's hemodynamics. Blood volume, heart rate, cardiac output all increase significantly. For a heart already working around congenital defect, these normal physiological changes can be profoundly compounded, really pushing the system to its limits.
Could you maybe give us a sense of the types of conditions that fall into each WHO risk category, just so we understand that progression of risk a bit better?
Certainly. For WHOI, which indicates no detectable increased risk, we're talking about women with very minor issues, or perhaps successfully repaired simple defects where the heart functions almost normally. Things like small ASDs or repaired PDAs. WHO2 indicates a small increased risk. This includes conditions like unoperated but stable septal defects, or maybe repaired tetralogy of Fallot, where the heart has adapted pretty well.
Okay, so those are relatively low risk. Then it steps up with 3.
Exactly. WHO3 signifies an intermediate increased risk. This covers conditions like milder forms of heart muscle weakness, certain valve diseases, or specific genetic syndromes like Marfan syndrome with more moderate heart involvement. It's about a careful balance of risk factors here.
And then into WHO3, which indicates significantly increased risk. What falls there?
Precisely. WHO3 covers conditions with more significant issues. Things like moderate heart muscle impairment, having mechanical heart valves which require very careful anticoagulation management, or complex circulations like the Fontan circulation, which we'll discuss later, even if they have a good clinical course. This category also includes unrepaired cyanotic heart disease or severe asymptomatic valve disease, where the body is already working much harder than it should be.
And finally, WHO4, the highest risk category. That sounds quite serious.
WHO-IV means an extremely high risk of maternal mortality or severe morbidity, making pregnancy generally contraindicated. This category includes the most severe forms of heart conditions, such as pulmonary arterial hypertension, severe systemic ventricular dysfunction, meaning the main pumping chamber is very weak, severe valve disease that is symptomatic, or any Fontan circulation that has complications. It also covers conditions like severe aortic dilatation, where the main artery is significantly enlarged. This detailed classification really helps clinicians understand and communicate the precise, nuanced risks involved, guiding both counseling and medical management effectively.
What's fascinating here is how those normal physiologic hemodynamic changes of pregnancy, which are significant for any woman, are just profoundly compounded in adults with CHD. Our sources also mention the CarPreg-2 weighted risk score, developed by Silversives and colleagues. Could you explain how that score works as a predictive tool? How does it help quantify risk?
Yeah, the carpreg-2 score is a critical, very practical tool for predicting the likelihood of cardiac events during pregnancy, moving beyond just a general classification. It assigns points to various individual risk factors. The highest weighted factors, each earning 3 points, include a prior history of cardiac events or arrhythmias, significantly decreased functional status, meaning the heart struggles with even minimal activity like NYHA class 3 or greater, and the presence of a mechanical heart valve, which carries its own significant set of risks, particularly around clotting and bleeding.
Okay, so those are the big 3-pointers, major red flags. What earns 2 points on that scale?
Factors like existing ventricular dysfunction, certain high-risk left-sided valve diseases or left ventricular outflow tract obstruction, pulmonary hypertension, coronary artery disease, and high-risk aortopathy, disease of the aorta, each receive 2 points. And finally, 1 point is assigned for a late pregnancy assessment, meaning evaluation happened later than ideal, or if there's been no prior cardiac intervention, which might suggest a less structured pre-pregnancy care plan. Using this scoring system, the predicted risks for cardiac events are stratified quite precisely. For a score of 1 point or less, the risk is about 5%. 2 points, it's 10%. 3 points, 15%. 4 points, 22%. And for scores greater than 4 points, the risk jumps significantly to 41%. This allows for a much more precise, data-driven risk assessment and a really tailored management plan for each woman.
That's a really critical tool for planning care, it sounds like. And beyond risk scores, medication review pre-pregnancy seems absolutely essential.
Oh, absolutely non-negotiable. Pre-pregnancy medications must be meticulously reviewed to ensure both maternal and fetal safety. It's imperative to discontinue any teratogenic agents, those are drugs known to cause birth defects. This includes commonly used heart medications like ACE inhibitors, ARBs, angiotensin receptor blockers, and endothelin receptor blockers. These are strongly contraindicated during pregnancy. Anticoagulation, which is vital for some patients, also requires highly individualized strategies, often involving a shift from oral medications like warfarin to injectable ones like heparin during pregnancy. Furthermore, a fetal echocardiogram between 18 and 22 weeks of gestation is routinely advised for patients with CHD to monitor the developing fetus for any cardiac abnormalities. And it's not just the women. Both men and women with CHD should receive thorough genetic counseling regarding the potential risk of CHD in their offspring, which actually points directly to the intricate genetic components we should probably unravel next. #tag3, congenital terminology, development, and genetics.
Yeah, that sounds like a perfect segue into understanding the very foundations of these conditions. Let's delve into the often confusing world of congenital terminology, the marvel of cardiac development, and the crucial role genetics plays. Our sources point out that one of the challenges in caring for adults with CHD is the inconsistent terminology used to describe the lesions. How did that inconsistency even come about, and what's the impact today?
Yeah, it's largely a historical issue, really a reflection of how rapidly our understanding evolved. Over time, multiple brilliant pioneers like Maud Abbott, Maurice Lev, Jesse Edwards, and later the Van Prez and Robert Anderson contributed invaluable insights and descriptions. But each sort of developed their own way of classifying these complex defects. And while their contributions were crucial, without a unified system right from the start, consistency became a significant challenge. The impact today is that, a doctor in one part of the world might use one term for a defect, while another uses a completely different term for the exact same condition. This can lead to potential confusion in communication and care planning, especially for patients who move or maybe seek second opinions from different centers.
Okay, so how do clinicians navigate that today? What's the preferred method for describing these complex conditions, trying to move towards more clarity?
The approach preferred in this chapter, and what's widely accepted in modern practice, is the segmental approach. This method basically breaks down the heart into its core segments, the atria, the ventricles, and the great arteries, and analyzes each one separately. Only after systematically evaluating each segment and how they connect is a comprehensive diagnosis formulated. This systematic approach is incredibly helpful. It brings clarity to even the most complex defects, almost like, disassembling a complicated machine into its core components to really understand how it works or doesn't work.
Can you explain the difference between segmental alignments and connections? They're both mentioned as crucial concepts in understanding complex defects, but they sound like they could be easily confused.
Yes, it's a key distinction and one that really highlights the precision needed here. Segmental alignment refers to the functional relationship, basically what drains into what. For example, in a normal heart, the right atrium is aligned with the right ventricle, and the left ventricle is aligned with the aorta. It's like knowing which room opens into which other room in a house. Segmental connection, on the other hand, describes how adjacent segments are physically linked together, the actual architectural joining. In a normal heart, the pulmonary artery is connected to the right ventricle by a complete muscular channel called a coteus or infundibulum, almost like a distinct hallway. Meanwhile, the aorta is connected to the left ventricle by a more direct fibrous continuity without that same muscular hallway structure. Understanding both alignment and connection is absolutely vital for accurately diagnosing and truly comprehending the complex pathophysiology of these defects. They are distinct, crucial pieces of the puzzle.
That brings us to cardiac development itself, which is truly incredible in its complexity and precision. When does the heart even start to form, and how quickly does it develop into what we recognize as a fully functioning organ?
It starts forming remarkably early, astonishingly early, actually just in the 3rd week of gestation. And it's nearly fully formed by a mere 8 weeks. It's an incredibly rapid and precise process, a true marvel of biological engineering. It begins with mesodermal precardiac cells. You can think of them as the foundational construction cells, migrating to form what we call cardiac crescents, basically the primary heart fields. These then come together as the embryo undergoes ventral closure to form a primary linear heart tube. Just a simple tube at first?
A simple tube initially. Okay, how does it rapidly transform into the complex, 4-chambered, highly efficient organ we know?
It's a really intricate dance. Cells from something called the second heart field keep proliferating and are continually added to this heart tube throughout embryogenesis. These are crucial because they contribute significantly to forming the atria, the right ventricle, and the outflow tract, the parts that form the exits from the heart. Additionally, cardiac neural crest cells, a special group of cells, play an absolutely essential role. They migrate into the developing heart during the 5th to 6th weeks of gestation and are indispensable for the septation of the outflow. That means forming the walls that divide the major arteries. They're also critical for forming the semilunar valves, the aortic and pulmonary valves, and the precise patterning of the aortic arches, which are the main vessels branching off the aorta.
Wow, that's a lot of specialized cells doing very specific high-stakes jobs. What happens after that initial tube is formed to give it its final shape?
Right, so once formed, that primary heart tube grows and elongates with the continuous addition of those second heart field cells. Because the ends of the heart tube are relatively fixed, sort of constrained by the developing pericardial sac, as it elongates, it has to bend or loop. In the vast majority of healthy hearts, this loop falls to the right, which is known as a D-loop. It's a critical directional cue in development. Further elongation then pushes the mid portion of the tube, which is destined to become the future ventricle's down or caudal relative to the inflow. This establishes the normal anatomical relationship between the atria and ventricles.
And the final steps then, to get to a fully formed, functioning heart.
Further growth pushes the outflow portion of the heart medially towards the middle, and this is associated with crucial outflow rotation. Both processes are absolutely essential for the normal, correct alignment of the great arteries, the aorta and pulmonary artery. While this remodeling is happening, the outflow itself is undergoing septation or division, again under the profound influence of those vital cardiac neural crest cells. The septation proceeds in a very specific direction, from distal to proximal, culminating in the precise formation and muscularization of the infundibular or muscular outflow septum. The septum strategically inserts onto the superior endocardial cushion, effectively walling the aorta into the left ventricle via a designated outflow foramen and directing the pulmonary artery directly into the right ventricle. It's an incredibly intricate, precisely choreographed dance of cellular migration, growth, and remodeling. Even a slight misstep can lead to a congenital defect.
And here's where it gets really interesting, connecting this delicate biological dance back to genetics. Our sources state that CHD is the most commonly occurring birth defect, and its cause, the etiology, is often multifactorial, meaning many factors can contribute. What are some of the key genetic considerations here, and why is this understanding so vital for long-term care?
Yeah, one of the most well-known associations and a powerful example of that genetic link is with trisomy 21, commonly known as Down syndrome. Children born with trisomy 21 have about a 50% chance of also having CHD, most commonly involving defects in the atrioventricular canal. Another significant area involves contratruncal defects, which affect the outflow tracts of the heart. These are strongly associated with several chromosomal abnormalities, most notably a deletion at chromosome 22q11, which leads to DiGeorge syndrome.
So are there specific clues, maybe on an echocardiogram or something, that might hint at this genetic association, especially for adults who might have been diagnosed before genetic testing was as common as it is now?
Yes, absolutely. Echocardiographic clues in patients with a contratruncal defect that might suggest a 22q11 deletion include things like an associated right aortic arch or an aberrant subclavian artery. These are subtle but potentially significant flags. It's incredibly important to recognize this because many adults currently living with contratruncal defects may not have been tested for DiGeorge syndrome in the past, often before such testing was widely available or even recognized as important. And this condition is critical to identify because it's associated not only with heart defects, but also with a variety of psychiatric disorders and cognitive disabilities. These profoundly impact their long-term care, their quality of life, and the approach to their overall health management.
Are there other genetic syndromes commonly linked to CHD that impact how we understand and treat these conditions in adults?
Absolutely. Noonan syndrome is another example. Individuals with this commonly present with a dysplastic or malformed pulmonary valve, along with distinctive facial features and lymphatic abnormalities. This syndrome has been linked to defects in specific genes, most notably one called PTPN11. Then there's Williams syndrome, which is characterized by a specific deletion on chromosome 7 at 7q11.23. Adults with Williams syndrome often present with supravalvar aortic stenosis, a narrowing above the aortic valve, and diffuse arteriopathy, meaning widespread artery disease. They also often have a distinct cocktail-like personality and hypercalcemia or high calcium levels. The growing importance of genome-wide analyses in individuals with CHD really cannot be overstated. As our understanding of these genetic underpinnings continues to expand, it allows for more precise diagnoses, personalized risk assessments, and potentially, future targeted therapies. It's truly redefining what normal health means for these individuals. Hashtag TAC4VA. Specific CHD lesions in detail.
Okay, let's now dive into some specific CHD lesions, moving from the general to the particular. We'll start with conditions that lead to a dilated right heart, as summarized in Table 269-3 in the sources. What are some of the congenital reasons for this, and what's the common thread among them?
Right. The common thread is basically anything that causes the right side of the heart to work harder or handle more blood volume than it's designed for, which leads to its enlargement or dilation. These causes, these etiologies, include congenital valvular anomalies like Epstein anomaly, which is a defect of the tricuspid valve, or pulmonary regurgitation, where the pulmonary valve leaks. We also see intrinsic right ventricular or RV myocardial anomalies like arrhythmogenic RV dysplasia or Ehlers anomaly, which are problems with the heart muscle itself. And finally, shunt lesions occurring proximal to the tricuspid valve can also lead to right heart dilation, as blood incorrectly flows into the right side before it even gets to the main pumping chamber. Cardiac imaging, like echo or MRI, is absolutely critical in figuring out the precise cause. And a thorough knowledge of the anatomy and physiology of these various shunt lesions is essential for accurate diagnosis and effective management.
One of the most common reasons for right heart dilation is an atrial septal defect, or ASD, right? Figure 269-2A illustrates this. How exactly does an ASD lead to a dilated right heart?
An ASD is essentially a hole in the wall separating the heart's two upper chambers, the atria. The physiology is predominantly a left to right shunt. This means that because the left side of the heart normally operates under higher pressure and contains oxygenated blood, that oxygenated blood flows incorrectly from the left atrium across the hole into the right atrium. From there, it goes into the right ventricle and pulmonary artery. This shunting increases the volume of blood the right heart chambers and the pulmonary arteries have to handle. This leads to chronic volume loading of the right heart and, consequently, its dilation. While large ASDs often present with symptoms in childhood, many smaller ones are discovered incidentally in adulthood, maybe during a routine checkup or imaging for something else entirely. The degree of shunting, and thus the extent of right heart volume loading, is determined mainly by the size of the defect and the diastolic properties of the heart, basically, how stiff or relaxed the heart chambers are when they fill.
That's interesting how aging factors can play a role here, too. Our sources say that as patients age, conditions like diabetes, high blood pressure, atherosclerosis
they can decrease the compliance or the stretchiness of the left-sided chambers. And this then contributes to increased left-to-right shunting, even through a stable ASD, leading to more noticeable symptoms. So an ASD that was quiet before could become problematic later in life.
Precisely, yeah. This makes the subtle signs even more important for diagnosis as patients get older. Clinically, patients with an ASD might exhibit an RV heave on palpation. You could feel the right ventricle actively pushing against the chest wall. And a classic fixed split S2 on auscultation. The fixed split S2 is a distinctive heart sound. It occurs because the prolonged right ventricular ejection time and the increased pulmonary artery capacitance delay the closure of the pulmonary valve, regardless of whether the patient is breathing in or out. It doesn't vary with respiration like a normal split S2 does. On an ECG, you commonly see an incomplete right bundle branch block pattern. When symptoms do occur, they typically include exercise intolerance, a tendency towards atrial arrhythmias, and shortness of breath with exertion. Though it's important to remember, many adults with incidentally found ASDs remain surprisingly asymptomatic for years.
So if an unrepaired ASD is causing the right heart to dilate, is that a reason for intervention even if the patient feels okay?
Yes, often it is. Right heart dilation without another clear explanation in the setting of an unrepaired ASD is considered a significant risk factor. Risk for progression to symptomatic right heart failure, the development of atrial arrhythmias like atrial fibrillation or flutter, and potentially down the line, pulmonary arterial hypertension or PAH. For this reason, a patient with an ASD and documented right heart dilation, especially if they are symptomatic, should generally be offered ASD closure. While pulmonary vascular disease leading to PAH develops in maybe up to 10% of patients with unrepaired ASDs, the really severe form known as Eisenmenger syndrome is actually a rare complication of ASDs. For patients who have both an ASD and significant PAH, management requires very careful and coordinated expertise between ACHD and pulmonary hypertension specialists. It's complex.
Okay. Our sources then detail the various locations of ASDs, as shown in Figure 269-2b. This helps differentiate them, as treatment can vary by type. It seems not all holes are created equal, huh?
Indeed, not all ASDs are the same. Their location is critical for understanding their embryology, their associated anomalies, and the best treatment strategy. The most common type is a secundum ASD. This is a true deficiency in the atrial septum right in the region of the fossa ovalis, the thin central part. This is distinct from a patent foramen ovo, or PFO. A PFO is just a persistence of the flap valve of the fossa ovalis. It's not a true hole, and it's not associated with right-sided cardiac dilation. PFOs are found in up to 25% of healthy adults and are usually only treated in very specific circumstances, like after certain types of stroke. Secundum ASDs, on the other hand, can often be closed percutaneously with occluder devices delivered via catheter, avoiding open heart surgery. Though very large defects, or ones with inadequate tissue rims or associated anomalous draining pulmonary veins, might still make surgical closure necessary.
And the other less common types of ASD.
Right. There's the primum ASD. This is a deficiency of the atrioventricular canal portion of the atrial septum, located lower down, closer to the valves. This type is always associated with abnormal development of the AV valves, most commonly resulting in a cleft or split in the mitral valve leaflet. Then there's a coronary sinus defect, which is quite rare. It involves an opening between the coronary sinus, the main vein draining the heart muscle itself, and the left atrium. Lastly, a sinus venous defect isn't a true septal defect at all, technically. It's a defect located either between the superior or inferior vena cava atrial junction and the right upper or lower pulmonary veins, respectively. So pulmonary veins drain incorrectly. Crucially, primum ASDs, sinus venous defects, and coronary sinus septal defects all require surgical closure due to their more complex anatomy and often associated anomalies. Catheter closure isn't usually an option.
Okay. Following closely is partial anomalous pulmonary venous return, PAPVR, which Figure 269-3 illustrates. How is this typically discovered in adults, and what does it mean for the heart's workload?
PAPVR is a condition where one or more of the pulmonary veins, which should normally drain oxygenated blood from the lungs into the left atrium, instead drain partially or completely into the right atrium or its venous connections like the SVC or IVC. This is occasionally discovered in adults who present with that same symptom of right heart dilation we discussed, or sometimes it's found incidentally on cross-sectional imaging, like a CT scan or MRI, done for completely different reasons. There are several possible anomalous connections. The most common involve a left upper pulmonary vein draining to an ascending vertical vein, which then goes into the innominate vein, or the right upper pulmonary vein draining directly into the superior vena cava SVC. In that latter case, you have to pay careful attention to make sure there isn't an associated sinus venous defect, as they often occur together. While concomitant pulmonary hypertension can occur, it's generally uncommon with isolated PAPVR.
And for these patients with PAPVR, is surgical repair always the way to go? Or is it a more nuanced decision?
Not necessarily always indicated, no. Symptomatology might be completely absent, even with significant PEPVR, as the body can compensate quite well sometimes. The decision to repair an isolated PEPVR depends on a careful consideration of several factors: the specific anatomy of the anomalous connection and where the blood is shunting, lung ventilation and perfusion patterns, how well the lungs are working, the hemodynamic response to the short, how much extra blood flow it causes, the presence and severity of any symptoms, and even the surgical experience available at the treating institution. It's a highly individualized decision, really balancing the risks and benefits of intervention versus just watchful waiting.
Let's move on to Epstein anomaly, another fascinating congenital tricuspid valve disease depicted in figure 269 at 4. This sounds quite unique. What exactly is this anomaly and how does it mess with the heart's function?
Epstein anomaly is a rare but very distinct congenital tricuspid valve disease. It stems from an embryologic failure of delamination, basically, a failure of the tricuspid valve leaflets to properly peel away from the underlying right ventricular muscle during development. Think of it like a valve that's sort of stuck to the wall of the heart instead of floating freely like it should. This results in the adherence of the valve leaflets to the underlying heart muscle, leading to a wide variety of abnormalities. These include an apical and posterior displacement of the functional tricuspid valve annulus, meaning the valve apparatus is pulled down into the ventricle further than normal. Also, dilation of the atrialized portion of the right ventricle that's a part of the ventricle that effectively becomes part of the right atrium because the valve is displaced so far down. And often there are fenestrations, holes, redundancy, floppiness, and tethering, typically of the anterior leaflet of the tricuspid valve. Functionally, the malformed tricuspid valve is usually regurgitant, meaning it leaks significantly, causing blood to flow backward into the right atrium. But sometimes it can be stenotic, meaning it's narrowed and obstructs forward flow into the RV.
So how does this actually present clinically in an adult, and what are the telltale signs for clinicians looking out for it?
The clinical presentation of Epstein anomaly in an adult is highly variable. It really depends on several factors: the extent of the leaflet distortion, the degree of tricuspid regurgitation, TR, the pressure within the right atrium, and whether there's an atrial level shunt like a PFO or ASD, which can sometimes relieve pressure but might also cause cyanosis if there's right to left shunting. On physical examination, the findings vary with severity. In more severe cases, you might hear a distinct split first heart sound, S1. And the second component of that S1 can have a distinctive snapping quality known as the Sale sign, which is due to the redundancy and abrupt movement of that large, malformed anterior tricuspid valve leaflet. Now, while patients with significant TR often have prominent V waves in their jugular venous pulsations, a visible pulse in the neck veins, this finding can actually be absent in Epstein anomaly. That's because the right atrial chamber can be abnormally large and compliant, sort of dampening the pressure wave. The ECG is often abnormal, usually showing signs of right atrial and right ventricular enlargement. And notably, up to 20% of patients with Epstein anomaly have evidence of ventricular pre-excitation, or a Wolff-Parkinson-White WPW pattern, which is an extra electrical pathway that can cause fast heart rhythms. Surgical treatment for this condition is complex, typically involving intricate tricuspid valve repair or sometimes replacement, closure of any associated atrial level defects, and often arrhythmia ablation procedures to address those extra electrical pathways if they're causing problems.
Okay, now let's pivot to shunt lesions that cause left heart dilation. Our sources note that these involve intracardiac shunts or intravascular passages that occur below the level of the tricuspid valve. What are the two major types of congenital shunts that fall into this category, contrasting them with the ASDs we just discussed, which affect the right heart? Right. The two major types that typically cause left heart dilation are ventricular septal defects, or VSDs, holes between the lower pumping chambers, the ventricles, shown in figure 269 to 5A, and a patent ductus arteriosus, or PDA, which is an open vessel connecting the aorta and pulmonary artery, shown in figure 269 to 6. Unlike ASCs, which primarily load the right heart, these lesions shunt blood at a point after the tricuspid valve, ultimately increasing the workload on the left side of the heart, the left atrium, and left ventricle. Starting with ventricular septal defects, VSDs, they're actually the most common congenital anomaly recognized at birth, yet they only account for about 10% of CHD in adults. Why the big discrepancy? What happens to most of them?
That's because there's a remarkably high rate of spontaneous closure of small VSDs during early childhood. The heart, particularly in infants, has a surprising natural ability to heal some of these smaller defects on its own. Large VSDs, on the other hand, they typically cause severe symptoms of heart failure and poor growth in infants, and are most often surgically closed before adulthood to prevent long-term damage and improve survival. So the VSDs we typically encounter in adults are usually those that were smaller to begin with, less symptomatic, and persisted into later life without needing early intervention.
And how are VSDs classified? Figure 269-5b illustrates various locations. It seems like with ASDs, the location is key here too.
Yes, absolutely. The location of a VSD is paramount because it dictates its clinical presentation, associated anomalies, and management strategy. The most common location is in the membranous septum, also sometimes referred to as paramembranous or outlet defects, near where the valves are. Muscular defects that persist into adult life are often quite small and become pressure and flow restricted as the surrounding muscle clamps down. This means they usually don't cause significant hemodynamic consequences or volume overload. AV canal defects, also known as inlet defects, are located low down in the septum, in the crux of the heart, and they are always associated with abnormalities of the atrioventricular valve leaflets, typically that cleft in the mitral valve we mentioned with primum ASDs. Lastly, subpulmonary defects, or conal-septal defects, are located just below the pulmonary valve. These are commonly associated with prolapse of the right coronary cusp of the aortic valve and subsequent aortic insufficiency or leakiness because the VSD undermines the support structure for the aortic valve right next to it. The good news, though, is that the outcome for adults with small VSDs, particularly those without evidence of ventricular dilation or pulmonary hypertension, is generally excellent.
And the physiology of a VSD, how does that lead to left heart dilation, as depicted in figure 269-5a? Where does that extra volume actually go?
Right. In a VSD, there's typically a left to right shunt. This happens because of the significant difference in pressure and outflow resistance between the higher pressure left ventricle and the lower pressure right ventricle during systole, when the heart pumps, and also differences in compliance during diastole when it fills. This means oxygenated blood from the left ventricle is incorrectly shunted across the hole into the right ventricle. This extra volume of blood then goes through the right ventricle into the pulmonary artery, increasing the blood flow to the lungs. From the lungs, this increased volume of now oxygenated blood returns to the left atrium and then the left ventricle. If this additional volume or the effects of it over time are significant enough, it leads to chronic volume overload, causing the left atrium and left ventricle to dilate or enlarge. This dilation can then predispose the patient to arrhythmias, symptoms like shortness of breath, dyspnea, and potentially over the long term, the development of pulmonary hypertension.
Okay, let's talk about the patent ductus arteriosus, or PDA, shown in figure 269-6. Where exactly is it located? What's its normal job in a fetus? And what happens when it stays open in an adult?
A PDA is a normal and actually vital blood vessel in a fetus. It connects the aortic isthmus, a part of the aorta just after the arch, and the origin of one of the branch pulmonary arteries, usually the left. Its role in the fetus is crucial. It allows blood pumped by the right ventricle to bypass the non-functional fetal lungs and go directly into the systemic circulation via the aorta. Normally, it's supposed to close shortly after birth, usually within the first few days of life, and it becomes just a ligament, the ligamentum arteriosum. When it remains patent or open in an adult, it allows blood to shunt between the aorta and the pulmonary artery. Small PDAs are often completely silent to auscultation and typically don't cause significant hemodynamic changes. However, a classic physical exam finding for a PDA, particularly a moderate or large one, is a continuous murmur, often described as sounding like machinery. It's usually best heard just below the left clavicle, and it extends all the way from systole past the second heart sound, S2, into diastole. This continuous sound reflects the constant flow, turbulence, and pressure gradient between the high-pressure aorta and the lower-pressure pulmonary arteries, resulting in continuous left-to-right shunting of blood throughout the cardiac cycle.
And a large PDA sounds like it could be quite serious then, putting significant strain on the heart.
Oh, it absolutely can be. Large PDAs lead to left heart dilation because oxygenated blood from the high-pressure aorta is shunted back into the lower-pressure pulmonary arteries. This creates a kind of recirculation of already oxygenated blood through the lungs, which then returns unnecessarily to the left atrium and left ventricle. This significantly increases the volume of blood flowing through the lungs, the left atrium, and the left ventricle, leading to their dilation and increased workload. Chronically, this can also result in progressively elevated pulmonary vascular resistance and, if it's severe and left untreated, potentially lead to Eisenmenger syndrome, that severe form of pulmonary hypertension with reversed shunt flow that we'll definitely need to discuss later. The physiology of the PDA, as you see in figure 269-6, essentially means oxygenated blood from the aorta shunts across to the pulmonary arteries. This leads to increased volume going through the lungs, returning to the left atrium, then the left ventricle, and then out the aortic valve again, putting a significant volume load predominantly on the left side of the heart. This can indeed cause left atrial and left ventricular dilation, arrhythmias, dyspnea, and pulmonary hypertension over time, #V, moderate and complex CHD lesions.
Okay, we've covered some relatively common lesions. Now let's move into the truly moderate and complex CHD lesions. These often require lifelong, highly specialized care. First up is Tetralogy of Fallot, or TOF. It's described as the most common cyanotic CHD, occurring at about 0.5 per 1,000 live births. It's depicted nicely in figure 269-7a and b. What exactly defines Tetralogy of Fallot, and how does this specific combination of defects create such a unique physiological challenge?
Yeah, Tetralogy of Fallot is a fascinating and complex condition. It arises from a single critical developmental anomaly. An anterior deviation, or forward shift, of the conal septum. That's the wall dividing the outflow tracts of the ventricles. This single anatomical issue results in 4 classic defects that always occur together, creating that unique physiological challenge. First, there's significant right ventricular outflow tract, or RVOT obstruction, a narrowing where blood exits the right ventricle trying to get to the lungs. Second, a large ventricular septal defect, VSD, is always present, allowing blood to shunt between the ventricles. Third, because of that RVOT obstruction, the right ventricle has to work much harder to pump blood, leading to right ventricular hypertrophy or thickening of its muscle wall. And fourth, the aorta, the main artery to the body, overrides the VSD, meaning it sits directly over the hole, receiving blood from both the right and left ventricles. It's really a spectrum of severity, ranging from patients with only mild pulmonary stenosis narrowing to those with complete pulmonary atresia, where the pulmonary valve is entirely absent. That's called 2O FPA. The core challenge is that deoxygenated blood from the right ventricle can now bypass the narrowed pulmonary artery, shunt across the VSD, and enter the overriding aorta, mixing with oxygenated blood from the left ventricle. This leads to cyanosis, that bluish discoloration of the skin due to low oxygen levels in the systemic circulation.
So, given that complex anatomy, what are the surgical strategies for TOF? And how have they evolved over time to improve outcomes for these kids?
Well, current surgical strategies typically involve primary repair in infancy, which is the standard now. The goal is to correct all 4 defects as early as possible. However, it's really important to remember that many adults living with repaired TOF today may have first undergone palliative procedures as children, often back in the mid-20th century. This was done to improve blood flow to the lungs before a complete repair was even feasible or safe. These palliative procedures included things like Blalock-Taussig shunts, pot shunts, or Waterston shunts, basically creating artificial connections to get more blood to the lungs. The ultimate goal of the complete surgical repair, as you can see in figure 269 says in CS, is twofold. Patch the VSD, thereby closing the hole between the ventricles, and surgically relieve the RVOT obstruction. Relieving that obstruction often involves enlarging the pulmonary valve annulus, the ring around the valve, frequently at the expense of sacrificing the integrity of the pulmonary valve itself, meaning it might become leaky after the repair. This commonly results in long-term pulmonary regurgitation, or PR, which is actually one of the key issues we need to manage in these patients as they reach adulthood.
Right. So even after what's considered a successful repair, there are these long-term hemodynamic sequelae consequences. Table 269-F4 lists several. Can you detail these for us and explain why ongoing surveillance is just so critical for these patients throughout their lives?
Certainly. Despite often dramatic improvements after repair, life after TOF repair comes with its own set of challenges, necessitating lifelong expert surveillance. Pulmonary regurgitation, or PR as I mentioned, is incredibly common following TOF repair because the surgery often compromises the pulmonary valve to relieve the obstruction. This usually leads to progressive right ventricular dilation over time as the RV has to handle more volume with each beat. Accurate quantification of RV size, function, and mass using imaging like MRI is particularly important in adults post-repair because RV dilation, dysfunction, and hypertrophy are strongly linked to adverse long-term outcomes, including arrhythmias and heart failure. Patients might also have residual RVOT obstruction. This narrowing can occur at various levels, beneath the pulmonary valve, at the valve itself, above the valve, or even out in the branch pulmonary arteries. Cardiac MRI has become routine for surveillance in these patients to precisely monitor these issues and quantify those ventricular volumes and blood flow non-invasively.
And are there issues with the left ventricle too? Not just the right side, even though the primary defect seems to be on the right?
Yes, surprisingly, and importantly so. Left ventricular dysfunction is present in at least 20% of adults with repaired TOF. This seems to be especially true for those who had the repair later in life, those who had prior palliative shunts that altered blood flow patterns for years, or those who have concomitant severe RV dysfunction. It really highlights how interconnected the entire heart is. And as these patients age, both atrial and ventricular arrhythmias occur with increasing frequency. A particularly concerning finding on a resting ECG is a QRS duration of 180 milliseconds or more. That's an electrical measurement reflecting the time it takes for the ventricles to depolarize or activate. This prolonged QRS duration has been strongly associated with an increased risk of dangerous ventricular tachycardia and sudden cardiac death in this specific patient population. This makes regular ECG monitoring and potentially more advanced electrophysiology studies crucial.
That's a pretty sobering statistic. So what's the overall long-term prognosis like for these patients? What does it tell us about the ongoing journey for someone with repaired TOF?
Well, while surgical repair has vastly improved survival for TOF patients compared to the pre-surgical era, it's crucial to understand it's not a complete cure. It's more like the beginning of a lifelong journey of management. One prospective follow-up study mentioned in the sources, involving 144 adults with repaired TOF, showed a 72% survival rate at 40 years post-repair, which is really remarkable progress. However, the cumulative event-free survival rate, meaning freedom from significant medical events, was significantly lower, only 25% in that same study. These events include things like the need for reintervention, most commonly pulmonary valve replacement, symptomatic arrhythmias requiring treatment, and episodes of heart failure. The most common reintervention is indeed pulmonary valve replacement, or PVR, to address that chronic progressive pulmonary regurgitation and RV dilation. However, the optimal timing for PVR in these patients remains a really complex clinical question, and there's ongoing debate. While PVR has been shown to decrease RV volumes and often subjectively improve symptoms like shortness of breath and fatigue, it has not yet been definitively proven to result in a significant improvement in ejection fraction or fewer adverse outcomes like ventricular arrhythmias or death in the long run. This is a critical nuance in the clinical decision-making process, balancing the benefits of intervention against the lack of proven long-term survival benefit in all cases.
That's a really critical nuance, yeah. Balancing symptoms versus hard outcomes. How is PVR typically done, and are there other interventions these patients might need down the line?
Traditionally, PVR has been done with open heart surgical procedures requiring a sternotomy, opening the chest, and cardiopulmonary bypass. However, more recently, percutaneous implantation of pulmonary valves using catheters inserted through blood vessels in the leg is increasingly being utilized in clinical practice. This offers a much less invasive option for many suitable patients. Beyond just PVR, adults with repaired TOF might also undergo other interventions over their lifetime. These can include closure of residual VSDs that might have been left intentionally or reopened over time, balloon dilation and a stenting of persistent RVOT obstruction or narrowings out in the Brandt's pulmonary arteries, and sometimes tricuspid valve repair if that valve has become significantly leaky due to the long-term strain on the right heart. And for patients who develop clinically significant and recurrent arrhythmias, catheter ablation procedures may also be beneficial to target and eliminate the abnormal electrical pathways causing the rhythm problems.
Okay, let's move on to another major complex condition. Transposition of the Great Arteries, or TGA. Our sources define this as the great arteries arising from the opposite side of the ventricular septum than normal. So the aorta comes from the RV and the pulmonary artery from the LV, as seen in figure 269a. What are the immediate clinical implications of this profound anatomical reversal? Why is it so dangerous right at birth?
This creates a unique and immediately life-threatening physiology right from the moment of birth. In the more common form, known as D-loop TGA, there's atrioventricular concordance, meaning the atria and ventricles are connected correctly, RA to RV, LA to LV. But there's ventricular arterial discordance, meaning the great arteries are switched. This results in two completely parallel circuits for blood flow, rather than the single series circuit you see in a normal heart. In essence, the body's circulation and the lungs' circulation are running totally separately, unconnected. Deoxygenated blood comes back from the body, goes to the right atrium, then the right ventricle, and is then pumped straight back out to the body via the aorta, never reaching the lungs to pick up oxygen. Meanwhile, oxygenated blood comes back from the lungs, goes to the left atrium, then the left ventricle, and is pumped straight back to the lungs via the pulmonary artery, never reaching the body. This leads to intense cyanosis very shortly after birth and is completely incompatible with long-term survival without immediate intervention, as the body rapidly becomes starved of oxygen. Patients with TGA are also often born with additional congenital defects, most commonly a VSD. Ironically, sometimes having a VSD can be a temporary lifesaver by allowing some mixing of oxygenated and deoxygenated blood between the two parallel circuits.
Wow. Okay, so given this absolutely dire situation, surgical repairs have evolved dramatically over time for D-loop TGA. What was the initial approach and what were its long-term trade-offs?
Right. Back in the late 1950s through the 1970s, the atrial switch procedures, like the Mustard and Senning procedures, were the groundbreaking interventions performed. You can see this illustrated in Figure 269-8b. These procedures effectively relieved the cyanosis by redirecting blood flow at the atrial level using surgically created baffles or tunnels made from pericardium or synthetic material. Venous blood was directed to the LVPA and pulmonary venous blood to the RV aorta. However, they left the patient with a systemic right ventricle, meaning the right ventricle, which is normally designed for the low-pressure pulmonary circulation, was now responsible for pumping blood to the entire high-pressure systemic body circulation. Despite enabling survival for decades for many patients, this approach came with multiple, quite worrisome long-term sequelae, as outlined in Table 269-5. These continue to challenge patients and clinicians today as this population ages.
And what are those long-term sequelae of the atrial switch? What's particularly concerning for adults living today with these older repairs?
The most worrisome complication is undoubtedly systemic RV dysfunction. The right ventricle simply isn't built structurally or functionally to sustain the high pressures of the systemic circulation for decades on end, leading to eventual failure in many patients. Its precise prevalence in this aging population isn't perfectly defined, but it's significant. And unfortunately, current medical therapies used for left ventricular failure are often ineffective in supporting a failing systemic RV. Other significant sequelae include sinus node dysfunction, which can lead to pathologically slow heart rates requiring pacemakers, and a very high incidence of atrial arrhythmias, like atrial flutter and fibrillation, largely due to the extensive surgery and scarring within the atria. Tricuspid regurgitation is also common, as the tricuspid valve, now acting as the systemic AV valve, is under unprecedented systemic pressure, causing it to leak over time. Patients may also experience baffle leaks or baffle obstruction, where the surgically created tunnels either leak, causing mixing of blood again, or narrow, obstructing blood flow. All these complications mean a lifelong need for highly specialized surveillance and proactive management for these atrial switch patients.
So those early surgeries definitely had their own set of challenges, highlighting the complex trade-offs in cardiac surgery back then. What came next in the evolution of D-loop TGA repair? And what's considered the gold standard today?
Well, for a specific subset of patients with D-loop TGA who also had a VSD and significant pulmonary stenosis, a Rastelli procedure might have been performed. This intervention involves closing the VSD in a way that directs LV outflow to the aorta, and then creating an external conduit or tube from the right ventricle to the pulmonary artery, bypassing the pulmonary stenosis. This also relieves cyanosis and has the significant benefit of establishing a systemic left ventricle, which is generally much more durable for long-term systemic circulation. However, it requires conduits that often need replacing later in life. But since the 1980s, the arterial switch operation, or ASO, depicted in Figure 269 at 8C, has become the undisputed surgical procedure of choice for most newborns with D-loop TGA. This procedure is truly revolutionary because it achieves both anatomic and physiologic correction. It involves transecting or cutting the great arteries just above their sinuses, where the valves sit, switching them back to their correct ventricles, and then, the most technically demanding part, meticulously translocating the coronary arteries from the old aorta route to the neo-aorta route, which was the original pulmonary route. This complex procedure, performed in infancy, has resulted in substantial improvements in long-term survival and vastly improved quality of life for these patients compared to the atrial switch era.
And for the ASO, which is the preferred modern approach, what are the long-term sequelae we need to watch out for, according to Table 2695? It sounds like even the most elegant solutions can have their own potential issues down the line.
Yes. Even with the arterial switch operation, while highly successful overall, potential long-term sequelae still require vigilant monitoring throughout life. These primarily include obstruction at the surgical anastomosis sites. This can manifest as narrowing, or stenosis, above the new pulmonary valve, supravalvular pulmonary stenosis, or above the new aortic valve, supravalvular aortic stenosis. Critically, obstruction can also occur at the tiny coronary artery orifices where they were reimplanted into the neo-aorta. This is obviously very serious as it affects blood flow to the heart muscle itself. There can also be more distal obstructions, sometimes from tension placed on the repositioned pulmonary arteries as the child grows, leading to narrowings in the branch PAs, or distortion or dilation of the neo-aortic root. These issues highlight that while the ASO offers a superior physiological outcome, it still involves incredibly complex neonatal surgery that requires careful, lifelong surveillance, particularly using imaging, to watch for these potential complications.
Now, there's another, less common form of TGA mentioned, the L of TGA, also known as congenitally corrected TGA, shown in Figure 269-9. Our sources say it's less common and might not require surgery initially. What makes it physiologically corrected, and what are its own unique set of long-term challenges?
Right, L-loop TGA is fascinating because it's a naturally occurring anatomical double switch that actually results in a physiologically corrected circulation, at least initially. What this means is there's both atrioventricular discordance, the right atrium connects to the morphologic left ventricle, and the left atrium connects to the morphologic right ventricle, and ventricular arterial discordance. The left ventricle pumps to the pulmonary artery, and the right ventricle pumps to the aorta. So, although the chambers and great arteries are switched from their normal positions relative to each other, the net effect is that deoxygenated systemic venous blood from the body correctly flows through the LV to the lungs via the pulmonary artery. And oxygenated pulmonary venous blood from the lungs correctly flows through the RV out to the body via the aorta. It's a natural correction, which is why many patients can be asymptomatic for years, even decades.
So it's a natural correction, but it sounds like there are still associated issues that tend to crop up later in life. What should patients and clinicians be aware of with LTGA?
Precisely. While often asymptomatic early on, patients with L-loop TGA commonly have associated congenital anomalies that can cause problems later. These include dextrocardia, where the heart is predominantly on the right side of the chest, associated ASDs or VSDs, a frequently dysplastic tricuspid valve. And remember, in this condition, the tricuspid valve is now the systemic atrioventricular valve, sitting between the LA and the systemic RV. It's under high pressure, making it very prone to leak TR over time. Pulmonary stenosis can also be present. Perhaps most critically, conduction system abnormalities are very common due to the abnormal course of the conduction tissue in this anatomy. Complete heart block, where the electrical signals from the atria don't reach the ventricles, occurs spontaneously in up to 30% of patients over their lifetime, often requiring a pacemaker. So those patients without significant associated defects might not present until later in life, often coming to attention with new symptoms of heart failure from the failing systemic RV, severe tricuspid regurgitation, or newly recognized conduction disease requiring intervention.
Okay, let's turn now to coarctation of the aorta, which Figure 269-10 illustrates. What exactly is it? And what are the classic physical exam findings that might clue a clinician into its presence, especially if it wasn't picked up in childhood?
Coarctation of the aorta is a congenital narrowing, typically a discrete shelf-like obstruction located at the descending aorta, usually just distal to the origin of the left subclavian artery, near where the ductus arteriosus, or ligamentum arteriosum, inserts. Less commonly, the narrowing can involve a longer segment or the transverse aortic arch itself. Think of it like a significant kink or constriction in the main pipe coming off the heart. On physical examination, the classic finding is a significant disparity between upper and lower extremity blood pressure and pulses. The blood pressure measured in the legs will be lower than in the arms, and the femoral pulses in the groin will feel weaker and delayed compared to the brachial or radial pulses in the arms. This difference might be less obvious if significant aortic collaterals, natural bypass vessels, usually from the intercostal arteries, have developed over time. These can partially circumvent the obstruction and equalize pressures somewhat. You might also hear a continuous murmur over the patient's back, between the scapulae, reflecting this turbulent blood flow through those collateral vessels trying to get around the narrowing.
And what's the physiological impact of this obstruction? It sounds like it creates a zone of high pressure before the narrowing.
That's precisely right. A significant coarctation dramatically increases the afterload, or the resistance the heart has to pump against, for all structures proximal to the obstruction. This includes the left ventricle, which has to pump much harder to get blood past the narrowing, leading to its thickening hypertrophy over time. It also increases pressure in the coronary arteries, the ascending and transverse aorta, and the cerebral and arm vessels, everything upstream of the blockage. So you end up with a high pressure zone before the coarctation, predisposing to issues like hypertension, particularly the upper body and head, while the lower body potentially experiences reduced blood flow and pressure.
Are there common associations with coarctation of the aorta that clinicians should be aware of, things that often go together?
Yes, definitely. A bicuspid aortic valve, An aortic valve with only 2 leaflets instead of the normal 3 is a very common concomitant lesion, found in a large percentage of coarctation patients. Typically, it's the type with right-left commissural fusion. This means if you find one condition, coarctation or bicuspid valve, you should always actively look for the other. Also, in women presenting with coarctation who also have short stature, a webbed neck, lymphedema, and primary amenorrhea, lack of menstruation, a concomitant diagnosis of Turner syndrome should be strongly considered. The presence of Turner syndrome is significant because it indicates a potentially greater degree of underlying vascular abnormality and increased risks from sequelae like aortic aneurysm or dissection, even after seemingly successful coarctation repair.
And what's the prognosis like after coarctation repair? Is it considered a complete fix, or do these patients need ongoing surveillance for life?
Patients who have undergone surgical or catheter-based repair, especially if done early in life, generally have a good prognosis, and repair vastly improves long-term outcomes compared to being left unrepaired. However, it's crucial to understand that it's not a complete cure in the sense of erasing all future risk. These patients remain at increased risk for several long-term issues. Systemic hypertension is very common and can persist or develop many years after successful repair. They also have an increased risk of premature atherosclerosis, left ventricular failure due to the long-standing, even if treated, pressure load, and critically, aortic aneurysm formation or dissection, particularly at or near the site of the original repair, as the aortic tissue itself may be abnormal. There's also a risk of recurrent coarctation at the repair site. So yes, lifelong surveillance, including meticulous blood pressure monitoring and management and regular imaging of the entire aorta, is absolutely crucial for these patients to catch and manage these potential long-term complications.
Finally, in our discussion of complex lesions, let's talk about single ventricle physiology. Our sources call it an imprecise term, but a useful one. What exactly does it refer to, and what are some common diagnoses that fall into this category, where the heart essentially functions with only one main pumping chamber?
Yeah, the term single ventricle physiology is indeed imprecise, but incredibly useful clinically. It's broadly used for a wide range of complex congenital heart conditions where one ventricle or its associated inflow or outflow valves are so severely underdeveloped or malformed that they effectively preclude the surgical creation of a standard biventricular circulation, meaning the heart simply cannot be surgically divided to effectively pump blood through two separate, fully distinct pulmonary and systemic circuits like a normal heart. Instead, one ventricle must serve either both the systemic and pulmonary circulations initially, or ultimately be surgically plumbed to be the primary pump for the systemic body side. Common congenital diagnoses that fall under this umbrella include things like tricuspid atresia, where the tricuspid valve is absent or fused shut, double inlet left ventricle, where both atria connect primarily to a single dominant left ventricle, and hypoplastic left heart syndrome, where the entire left side of the heart, including the mitral valve, left ventricle, aortic valve, and ascending aorta, is severely underdeveloped.
And for most patients born with this type of physiology, the surgical pathway culminates in what's known as a Fontan procedure, illustrated in Figure 269-11A and B. This sounds like an incredibly complex and ingenious surgical solution. Can you tell us a bit about the history and the key features of this procedure?
The Fontan procedure has a really fascinating and relatively recent history in cardiac surgery. It was initially conceived and first successfully used by Dr. Francis Fontan for tricuspid valve atresia back in 1971, which was truly groundbreaking at the time. Since then, multiple modifications and refinements have occurred, evolving into the complex, often staged surgical pathway it represents today. Its key defining feature is the near-complete separation of the pulmonary and systemic circulations, but achieved in a very unique way, bypassing the need for a functional subpulmonary ventricle, usually the RV. In a Fontan circulation, the single functioning ventricle, which could be a morphologic LV or RV, pumps oxygenated pulmonary venous blood through the aorta out to the body. The truly ingenious and physiologically challenging aspect is the passive flow of deoxygenated systemic venous returned directly to the lungs without a pumping chamber to actively propel it forward. This is achieved via surgically created connections. For example, the superior vena cava, SVC, and inferior vena cava, IVC, which bring deoxygenated blood back from the upper and lower body, are disconnected from the atrium and connected directly to the pulmonary artery. This connection might be via an internal tunnel created within the atrium, or more commonly now, using an extracardiac conduit, a synthetic tube running outside the heart. This guides the systemic venous blood flow directly into the lungs, completely bypassing the single ventricle.
So the right side of the heart effectively doesn't have a pump pushing blood to the lungs. The blood flows there simply because of pressure differences between the veins and the pulmonary arteries. That's a massive departure from normal physiology. And
sounds like it would inevitably create unique long-term challenges.
Indeed, it's a profound physiological shift, absolutely. In normal adults, pressure is actively generated by the right ventricle to propel blood from the lower pressure right atrium through the lungs to the higher pressure left atrium. In the Fontan circulation, by definition, due to the absence of a pumping chamber driving blood into the pulmonary artery, the systemic venous pressure, and thus the right atrial or Fontan pathway pressure, must be higher than the left atrial pressure to allow any passive forward flow through the lungs. This creates a state of chronically elevated systemic venous pressure that inevitably impacts many other organ systems over time. As a result, patients who have undergone a Fontan procedure are unfortunately at significant risk for multiple complex comorbidities as they reach adulthood. These are a major focus of their lifelong specialized care. These include chronic atrial arrhythmias, very common due to atrial dilation and scarring, progressive heart failure, or dysfunction of the single systemic ventricle. Significant renal dysfunction, and particularly hepatic dysfunction, so-called Fontan-associated liver disease, or FLD, due to the chronic liver congestion from high venous pressures, and a markedly increased risk of both venous and arterial thrombosis, blood clots, and embolism. It's truly a testament to surgical ingenuity that allows these patients to survive, but it also creates a unique, complex, and often fragile physiological state that requires highly specialized multi-organ system management throughout their lives.
That's a profound transition, thinking about the Fontan. Let's move now to a severe consequence of certain long-standing, unrepaired congenital heart defects. Eisenmenger syndrome, or ES. This is a condition many people might have heard of but might not fully grasp. What exactly defines this condition, and how does it develop?
Right. Eisenmenger syndrome is essentially the severe end-stage consequence of a long-standing significant left-to-right shunt, like a large VSD, a large PDA, or sometimes other complex defects that wasn't repaired or wasn't repaired early enough. Initially, with these defects, blood flows predominantly from the higher pressure left side of the heart, or aorta, to the lower pressure right side, or pulmonary artery. This massively increases blood flow going through the lungs. Over years, this chronic excessive pulmonary blood flow, or sometimes excessive pressure, leads to irreversible damage and remodeling of the small pulmonary arteries. They become thickened and narrowed. This causes a severely increased pulmonary vascular resistance, PVR. Eventually, this resistance becomes so high that it equals or even exceeds the systemic vascular resistance. When that happens, it reverses the direction of the shunt. Now, blood flows predominantly right to left. This means deoxygenated blood from the right side of the heart bypasses the lungs entirely and flows directly through the defect into the systemic circulation. This causes profound chronic cyanosis and has widespread effects on multiple organs. It's a critical, often late-stage complication of untreated shunts.
So it's not just a heart condition then, but fundamentally a multi-organ condition because of that chronic lack of oxygen and high pressure.
Precisely, yeah. ES is fundamentally a multi-organ condition. The systemic desaturation, low oxygen, and the elevated right-sided and venous pressures impact virtually every system in the body: brain, kidneys, liver, blood system, joints, everything. It can theoretically occur with any CHD that initially presents with a significant left-to-right shunt if it remains unrepaired or is repaired too late after irreversible pulmonary vascular changes have set in. The natural history of ES is highly variable. But interestingly, despite the significant morbidity and challenges these patients face, adults with ES generally tend to survive longer than adults who develop other forms of severe pulmonary arterial hypertension, like idiopathic PAH, without a congenital shunt. This might be partly due to the shunt itself acting as a pop-off valve, potentially protecting the right ventricle from experiencing the absolute highest pressures seen in other forms of PAH.
Given its complexity, what are the key medical care recommendations for managing Eisenmenger syndrome? What are some of the critical balances clinicians have to strike?
Medical care for ES is highly specialized and focuses largely on supportive measures and managing the numerous complications. Key recommendations include sustaining adequate hydration. Dehydration can worsen blood viscosity and cyanosis, so that's crucial. Actively avoiding and treating anemia is also vital. Iron supplementation should be used when appropriate because anemia further reduces the already compromised oxygen carrying capacity in a system that's chronically desaturated. Anticoagulation, however, remains quite controversial. Patients with ES have both an increased risk of thrombosis, clots, especially in the pulmonary arteries, and a predisposition to bleeding, including the frequent and sometimes life-threatening occurrence of clinical hemoptysis coughing up blood. So deciding whether or not to anticoagulate requires a very careful, individualized assessment of the balance between thrombotic risk and bleeding risk. It's a really delicate tightrope walk.
That sounds like a very difficult balance indeed. What about managing hematocrit levels?
Given the chronic cyanosis, the body makes extra red blood cells, right? So the blood gets thick. But it sounds counterintuitive to thin the blood in someone who's already low on oxygen.
It is indeed a very nuanced approach. Elevation of hematocrit, the percentage of red blood cells, often occurs as the body tries to compensate for the chronic low oxygen levels. This is called secondary erythrocytosis. If the hematocrit elevates significantly above what's considered appropriate for the degree of cyanosis, and the patient is experiencing hyperviscosity symptoms like severe headaches, dizziness, visual changes, or excessive fatigue, then it might need management. Often this can be managed simply by ensuring adequate hydration alone, which helps lower viscosity. On occasion, phlebotomy or bloodletting with isovolumic replenishment, meaning carefully replacing the removed blood volume with saline to avoid dehydration, can be performed. But this is specifically reserved for symptomatic patients with documented hyperviscosity. It's absolutely crucial to note that routine phlebotomy in asymptomatic adults with ES is strictly contraindicated. Why? Because it can paradoxically worsen iron deficiency, deplete functional red blood cells, and actually impair oxygen delivery even further, often making the patient feel worse, not better. Conversely, appropriate optimization of iron stores through careful iron supplementation has been demonstrated to significantly improve quality of life and functional performance in adults with ES who are found to be iron deficient, which many of them are.
And for women of childbearing age with Eisenmenger syndrome, what are the considerations around contraception and pregnancy? It sounds like an incredibly high-risk situation.
It is an extremely high-risk situation, perhaps one of the highest risks in all of medicine. Effective contraception is strongly recommended, essentially mandatory, for women with ES who are of childbearing age. And it's vital to avoid the use of estrogen-containing contraceptives, as estrogen may be thrombogenic, further increasing the already high risk of dangerous blood clots in these patients. Progestin-only or barrier methods are preferred. Pregnancy is unequivocally contraindicated in women with Eisenmenger syndrome. The risk of maternal mortality is extremely high, reported to be as high as 30–50% in some series. The massive physiological demands of pregnancy put an absolutely unbearable strain on an already severely compromised cardiopulmonary system. It's just incredibly dangerous for both the mother and the fetus, making careful counseling and ensuring effective, reliable contraception paramount.
Are there any newer therapies emerging for ES, or is transplantation really the only potential option in severe cases?
The landscape of therapy is slowly expanding, though options remain limited compared to other forms of PAH. Recent evidence suggests that the use of selective pulmonary vasodilators medications specifically designed to relax the blood vessels in the lungs, like endothelin receptor antagonists, for example, bosentan, or phosphodiesterase 5 inhibitors, example, sildenafil, may be efficacious in some patients with ES. These therapies can help manage the pulmonary hypertension component, potentially improve symptoms, exercise capacity, and maybe even hemodynamics. However, they don't reverse the underlying condition. For select patients with very severe progressive disease and refractory symptoms despite medical therapy, transplantation may be a consideration. Historically, this often meant combined heart-lung transplantation. However, preferably, if the patient's single ventricle function is still reasonably preserved, lung transplantation with concomitant surgical repair of the intracardiac defect, like closing the VSD or PDA, is pursued if feasible. This avoids the need for a heart transplant if the patient's native heart is still capable of supporting the systemic circulation once the high pulmonary vascular resistance is relieved by the new lungs. This option, however, requires meticulous patient selection in highly specialized surgical centers. #VLI, palliative care and global considerations in ACHD.
Given the profound complexities and the chronic, often progressive nature of many ACHD conditions, which we spent so much time detailing, it seems like palliative care would play a significant and maybe often overlooked role. Our sources suggest that adults with CHD demonstrate quality of life-limiting comorbidities and premature mortality, far exceeding their age-matched peers without CHD. What does this mean for their actual symptom burden? How does it compare to other chronic illnesses?
It's a critical realization, absolutely. The symptom burden for many ACHD patients is considerable, and it often starts at a much younger age than we typically associate with severe chronic illness. The reported prevalence of symptoms like pain, anxiety, depression, shortness of breath, dyspnea, and fatigue appears strikingly similar to that reported for adults who are literally decades older and are engaged in palliative care for advanced acquired cardiovascular disease, like severe heart failure, often near the end of life. This comparison really underscores the chronic and often debilitating nature of living with complex ACHD. It emphasizes that these are not just anatomical defects fixed in childhood, but lifelong conditions with a profound impact on daily functioning, emotional well-being, and overall quality of life.
And what are the end-of-life outcomes like for these patients? And what critical gap do our sources identify in their care leading up to that point?
Sadly, despite their younger age compared to, say, many cancer patients at the end of life, adults with ACHD experience higher frequencies of hospitalization, intensive care unit ICU admission, 30-day readmission rates, and increased length of hospital stay during their final months or year. This can represent a profound challenge for patients and their families, potentially leading to prolonged suffering in intensive, highly medicalized settings. Our sources also point out a critical gap in their care. In one retrospective study of ACHD patients who died during a hospital admission, only a minority had actually engaged in documented end-of-life discussions or advanced care planning with their providers. This suggests that many patients may not have had their wishes, values, and preferences for care at the end of life fully explored, documented, or honored.
That's a really heartbreaking statistic, especially given the high symptom burden you just described. What's the disconnect there? Why are these crucial conversations not happening more often?
Well, surveys of both adults living with CHD and their healthcare providers suggest that the overwhelming majority of patients wish to participate in advanced care planning and discussions about palliative care options. They want to have these conversations. However, this desire contrasts sharply with statements from ACHD care providers, who often express significant uncertainties regarding prognostication, predicting the likely course of illness in this unique and heterogeneous population. They also often voice concerns about initiating such sensitive discussions with patients who may still be relatively young adults. The solution, therefore, seems crucial. Palliative care specialists who are either embedded within or closely aligned with ACHD care teams can play an incredibly important and iterative role. They can help define and address the alignment of patient goals and clinician goals within the boundaries of these frequently complex care decisions, doing so across the entire adult lifespan, not just at the very end. They can bridge that communication gap, provide much-needed expertise in managing complex symptoms and psychosocial needs, and help navigate those incredibly difficult but necessary end-of-life conversations with skill, sensitivity, and expertise.
That's a really powerful call for integrated care, bringing palliative care expertise in earlier and more consistently. Let's broaden our perspective now to global considerations. As survival patterns improve for all medically complex patients, not just ACHD, general internists and practitioners worldwide are increasingly facing the need to provide lifelong care for these individuals. This isn't just a U.S. phenomenon, right? It's a global challenge.
Indeed, it's a growing demand worldwide, particularly perhaps in developing nations where access to highly specialized ACHD care centers may be limited or non-existent. While evidence consistently shows that care for adults with CHD provided within medical centers that have dedicated ACHD specialty care programs is associated with improved overall survival. The current reality, analyses suggest, is that the majority of adults living with CHD globally actually seek and receive their medical care outside of such dedicated specialty centers. They are often managed primarily by general practitioners, family doctors, general internists, and general adult cardiologists who may not have the specific depth of expertise required for these incredibly nuanced conditions.
So what are the unique challenges for these patients who might not have consistent access to that specialized care? And what's the call to action for the ACHD community globally to address this?
These patients present an extraordinary challenge to the healthcare systems they interact with. Underneath the surface that often shows remarkable adaptability and determination, adults with CHD present a really wide spectrum of cognitive and functional performance levels. They also live with multiple organ system comorbidities, complex abnormalities of their systemic and pulmonary vasculature, and, as we discussed, a near universal presence of heart failure of one stage or another, all persisting over an entire lifetime. This incredibly complex multi-system profile makes their care exceptionally challenging outside of a highly specialized multidisciplinary setting. Therefore, it seems incumbent upon the ACHD specialists and the established ACHD specialty care centers to serve as hubs, as beacons of expertise and support, not just for patients, but for other providers too. Their critical role moving forward globally is likely to partner proactively with general practitioners and general cardiologists, encouraging engagement up to the level of their highest competencies and providing ongoing education, consultation, oversight, and support. This kind of collaborative hub-and-spoke model seems essential, with the ultimate shared goal of achieving optimal outcomes for this truly unique and rapidly growing patient population worldwide. Tag AFA, pericardial disease, chapter 270.
We've covered a vast, intricate landscape of adult congenital heart disease. Whew! Okay, now let's shift gears completely to another critical area of cardiovascular health, pericardial disease, drawing now from chapter 270 of our sources. Before we dive into what can go wrong with the pericardium, let's just establish a baseline. What are the normal functions of that sac surrounding the heart?
Right. The normal pericardium is a double-layered sac. It consists of the outer, tougher, fibrous parietal pericardium and the inner, delicate visceral pericardium, which is directly adhered to the heart surface, also called the epicardium. Between these two layers, there's normally a small quantity of lubricating fluid, typically only about 15 to 50 milliliters. This fluid is an ultrafiltrate of plasma, meaning it's mostly water and small molecules that have filtered out of the blood. The pericardium serves several important functions, acting almost like a protective yet flexible anchor for the heart. First, it acts as a restraining force. It helps prevent sudden excessive dilation or stretching of the cardiac chambers, especially the thinner-walled right atrium and right ventricle, for instance, during vigorous exercise or periods of acute fluid overload. Second, it helps restrict the heart's anatomic position within the chest cavity, keeping it relatively stable. And importantly, it likely plays a role in retarding the spread of infections from adjacent structures like the lungs and pleural cavities directly to the heart muscle itself. It acts as a barrier.
Okay, so if it's so important for these functions, what happens if it's entirely absent? That seems like it would cause significant problems, but our sources have a kind of surprising insight on this.
Yeah, what's fascinating here, and perhaps counterintuitive, is that total absence of the pericardium, whether it's congenital, meaning someone is born without it, which is rare, or it occurs after cardiac surgery where it's intentionally removed, surprisingly does not produce obvious clinical disease in most cases. The heart can generally function quite well without it. However, in cases of partial left pericardial defects where only a portion of the sac is missing, usually on the left side, the main pulmonary artery and sometimes the left atrial appendage may bulge or herniate through that defect. Very rarely, this can lead to actual herniation and subsequent strangulation of the left atrial appendage, which is a true surgical emergency that can compress the heart and cause sudden death. So, while total absence might be relatively benign, partial defects can pose a rare but significant, potentially life-threatening risk due to the possibility of mechanical compression or strangulation.
Okay, let's focus now on acute pericarditis, which our sources state is by far the most common pathologic process involving the pericardium. For clinicians trying to diagnose this, and for us to understand it, what are its four principal diagnostic features? Let's start with the classic chest pain.
Right. Acute pericarditis often presents with quite severe chest pain, and the character of this pain is a key differentiator. It's typically retrosternal felt behind the breastbone and/or left precordial on the left side of the chest. It commonly radiates to the neck, arms, especially the left, or the left shoulder. It's frequently described as pleuritic, meaning it's sharp and significantly aggravated by taking a deep breath, inspiration, coughing, or sometimes even swallowing. This is often due to accompanying inflammation of the pleura, the lining of the lungs, which sits right next to the pericardium. However, at times, the pain can be more steady or constricting, and it might radiate to the trapezius ridge, that ridge of muscle along the top of the shoulder and neck. This specific radiation pattern is quite suggestive of pericarditis. Crucially, this pain can remarkably resemble the crushing pain of myocardial ischemia or heart attack. This similarity often leads to confusion and potential misdiagnosis in emergency settings, especially when pericarditis is associated with ECG changes or elevated cardiac biomarkers like troponin.
So how do clinicians differentiate it from a heart attack then? Especially if the pain sounds so similar and those biomarkers might even be elevated. What's the key aha moment or clue for diagnosis?
The key differentiating characteristic, often the clinical aha moment, is that pericardial pain is typically intensified by supine lying flat on the back and is noticeably relieved by sitting up and leaning forward. This positional change is a real hallmark of pericarditis. Leaning forward shifts the heart's position within the inflamed pericardial sac, presumably easing the friction or pressure on the inflamed layers. It's also important to remember that significant pain might actually be absent in more slowly developing subacute or chronic forms of pericarditis, such as those caused by tuberculosis, post-irradiation from cancer treatment, neoplastic, cancer-related pericarditis, or uremic pericarditis from kidney failure. But in the acute setting, that positional nature of the pain is key. The differentiation from an acute myocardial infarction, AMI, can be particularly challenging when, with acute pericarditis, serum biomarkers of myocardial injury, like troponin, are also elevated. This indicates some degree of associated myocardial inflammation, myopericarditis, alongside the primary pericardial inflammation.
Got it. Our sources then provide a clinical classification of pericarditis in Table 271. Could you outline these classifications? It gives us a sense of the time frames and what they imply about how the disease might progress.
Sure, the clinical classifications are based primarily on the duration and specific presentation of the disease, which helps guide both diagnosis and treatment approaches. First, we have acute pericarditis, which by definition lasts less than 6 weeks. This can manifest either as fibrinous pericarditis, meaning there are inflammatory fibrous adhesions forming and often a classic friction rub sound heard with a stethoscope, or as effusive pericarditis, involving significant fluid accumulation within the pericardial sac. This effusion can be serous, clear, straw-colored fluid, or sanguineous, bloody fluid. Second, there's subacute pericarditis, which lasts longer, typically between 6 weeks and 6 months. This category includes more persistent forms, such as effusive constrictive pericarditis, where there's both ongoing fluid accumulation and evidence that the stiffening pericardium is starting to constrict the heart's filling. It also includes purely constrictive pericarditis that develops over this time frame. Finally, chronic pericarditis persists for more than 6 months. This can also be constrictive, where the pericardium becomes scarred, thickened, and calcified, tightly squeezing the heart and impairing its filling. Or it can be adhesive, meaning non-constrictive, where the layers simply stick together due to chronic inflammation or scarring, but without significantly restricting the heart's overall function.
Okay. And beyond the clinical presentation and timing, Table 271 also lists an extensive etiologic classification, basically, all the different causes. This covers a vast array, from infections to autoimmune responses. Let's start with the broad categories of infectious causes.
Right. Infectious causes are quite diverse and include a really wide range of potential pathogens. Viral etiologies are by far the most common cause of acute pericarditis in developed countries, often occurring after preceding respiratory or gastrointestinal viral illness. Common culprits include Coxsackie virus A and B, equivirus, influenza, Epstein-Barr virus, mono, cytomegalovirus, CMV, herpes viruses, mumps, adenovirus, hepatitis viruses, and HIV. Often a specific virus isn't identified, leading to a diagnosis of idiopathic pericarditis, which is presumed viral. Pyogenic or bacterial pericarditis is much less common now thanks to antibiotics, but it's far more severe, often leading to pus accumulation, purulent pericarditis, and high mortality if not treated aggressively. Bacteria involved can include pneumococcus, streptococcus, staphylococcus, Neisseria, Legionella, and chlamydia, often spreading from pneumonia, empyema, or bloodstream infections. Tuberculous TB pericarditis is another significant infectious cause, still prevalent in certain geographic areas, particularly developing countries, and also seen in immunocompromised populations like those with HIV. TB pericarditis is notorious for progressing insidiously and often leading to severe constrictive pericarditis if not diagnosed and treated properly with anti-TB drugs. Fungal infections can also be responsible, such as histoplasmosis, coccidioidomycosis, valley fever, candida, and blastomycosis. These are often seen in specific endemic geographic regions or, again, primarily in immunocompromised individuals. And then there are other, much rarer infectious causes like syphilitic pericarditis or those caused by protozoa or parasites usually seen in specific contexts or locations.
That's a huge range of infections. What about the non-infectious causes? These seem equally diverse and sometimes quite surprising.
They are indeed. Non-infectious pericarditis can arise from a multitude of sources. Acute idiopathic pericarditis is actually one of the most common diagnoses overall, essentially meaning we can't pinpoint a specific cause after reasonable investigation. As mentioned, it's often presumed to be viral but remains unproven. Renal failure, particularly end-stage renal disease leading to uremia, can cause a fibrinous or effusive pericarditis as metabolic toxins build up and irritate the pericardium. Neoplasia, meaning cancer, can involve the pericardium directly. This can be from rare primary tumors like pericardial mesothelioma, but much more commonly it's due to metastatic spread from other cancers, particularly lung cancer, breast cancer, lymphoma, or leukemia. Malignant effusions can cause tamponade. Trauma is another cause, whether it's penetrating chest wall injuries like stab wounds or non-penetrating blunt trauma like from a car accident steering wheel injury. These can cause pericarditis due to bleeding into the sac, hemopericardium, or direct inflammation. Aortic dissection, particularly Stanford type A involving the ascending aorta, is a critical life-threatening cause. If the dissection ruptures or leaks into the pericardial sac, it causes acute hemopericardium and often fatal cardiac tamponade. Acute myocardial infarction can lead to pericarditis in 2 ways. An early form, peri-infarction pericarditis, due to inflammation spreading from the damaged heart muscle occurring within days, or a delayed form. Post-irradiation pericarditis is a recognized complication following radiation therapy to the chest, often for cancers like breast cancer or lymphoma. It can occur months to years later and may lead to effusion or constriction. Certain genetic or autoinflammatory syndromes like familial Mediterranean fever and other periodic fever syndromes, or specific rare forms of familial pericarditis like Mullebray-Nanism, are also recognized causes. Lastly, certain metabolic conditions like severe myxedema from profound hypothyroidism and rarely very high cholesterol levels, cholesterol pericarditis, can contribute.
And finally, that last category. Causes presumably related to autoimmunity, where the body's own immune system might mistakenly attack the pericardium.
Exactly. This group includes a range of systemic inflammatory and autoimmune conditions where pericarditis is a known manifestation. Conditions like acute rheumatic fever, an inflammatory reaction following a strep throat infection, now rare in developed countries, classically caused pericarditis. Various collagen vascular diseases, where the immune system attacks connective tissues throughout the body, frequently involve the pericardium. Examples include systemic lupus erythematosus, SLE, rheumatoid arthritis, RA, ankylosing spondylitis, scleroderma, and granulomatosis with polyangiitis, formerly Wegener's. Pericarditis can be a presenting feature or occur during flares of these diseases. Certain drug-induced causes are also well recognized, where specific medications trigger an immune-mediated pericarditis, sometimes as part of a lupus-like syndrome. Classic culprits include procainamide, hygelazine, phenytoin, isoniazid, minoxidil anticoagulants, leading to hemopericardium, and mastocergesia. Stopping the offending drug usually resolves the pericarditis. Lastly, there are the post-cardiac injury syndromes. These are presumed to have an autoimmune basis, triggered by initial injury to the heart or pericardium. They can occur after pericardiotomy, surgical incision of the pericardium, common after cardiac surgery, after traumatic injury to the heart, or following a myocardial infarction. Specifically, Dressler syndrome refers to this delayed pericarditis occurring weeks or even months after a heart attack. This comprehensive etiologic classification really helps clinicians narrow down the potential causes when faced with a patient with pericarditis. It guides the diagnostic workup and ultimately the specific treatment, highlighting the systemic nature of many pericardial diseases and why a holistic view of the patient is always absolutely paramount. Hashtag tag outro.
Wow, what an incredibly expansive deep dive we've taken today. We've journeyed through just an immense amount of ground, haven't we? From the intricate, almost miraculous developmental processes of the human heart to the complex, lifelong landscape of living with and treating congenital heart disease in adulthood. We navigated the specialized care pathways, the critical surgical considerations, the profound genetic underpinnings, and even delved into specific, nuanced lesions like ASDs, VSDs, Tetralogy of Fallot, and Transposition of the Great Arteries.
And we didn't stop there, did we? We explored the multi-organ impact of severe conditions like Eisenmenger syndrome and really highlighted the crucial yet often overlooked role of palliative care throughout the ACHD journey, emphasizing the human experience behind these complex diagnoses. Then we completely shifted gears to demystify pericardial disease, detailing its normal protective functions, the critical diagnostic features of acute pericarditis, and its incredibly diverse clinical and etiological classifications. It really reminds us how interconnected the body truly is.
Yeah, our mission was for you, the listener, to walk away with an understanding pretty close to that of an elite professional in this field. Someone who doesn't just know the facts, but really grasps the deep implications. And if you've been listening closely today, you now have a far deeper, more nuanced grasp of these conditions, the intricate care pathways involved, and the profound challenges faced by both patients and the clinicians who care for them. You're truly well-informed now, with a real shortcut to understanding the cutting edge of this complex medical world.
So, thinking ahead, as our understanding of genetic factors and the long-term sequelae of these complex conditions continues to grow, and as medical technology relentlessly advances, what innovations do you anticipate will most significantly transform the lifelong care of adults with congenital heart disease? And how might that fundamentally redefine what normal health and a truly fulfilling life look like for millions of people across the globe?
It's a really fascinating question for the future of medicine, isn't it? Pushing us to imagine entirely new possibilities for these patients. We hope this deep dive has not only informed you, but also encouraged you to reflect on the immense importance of specialized care, ongoing research, and truly compassionate, integrated support in these incredibly complex and constantly evolving fields. Thank you so much for joining us on the deep dive. We'll see you next time.